Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this image here? You should be able to at least describe this as polycystic, right? Ring a bell? Polycystic kidney disease. I know you've heard of it. We're going to be discussing this and much more in this very important lecture on congenital pathology of the kidney pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Congenital pathology of the kidney pathology. Congenital pathology of the kidneys are disorders that affect the kidneys at birth. Right? Can you recognize what's going on here in this image to the right? CT scan. Kidneys shouldn't be connected. Ah, yes. Horseshoe kidney. You remember that? You actually have a differential for that. If this is a female, what condition does she most likely have? Turner syndrome, maybe? In this section, there are key concepts that you must be familiar with. Because congenital pathology of the kidneys that's going to show up include congenital horseshoe kidney, renal agenesis, dysplastic kidney, polycystic kidney disease for sure, and medullary cystic kidney disease. So let's talk about this horseshoe kidney. A horseshoe kidney is a type of anomaly where the kidneys are conjoined. And you can even see that in this x-ray. You see that? It's this intravenous pyelogram showing the horseshoe kidney. Horseshoe kidneys are the most prevalent congenital renal abnormality. And the connection is usually at the lower pole. Horseshoe kidney can become stuck on the inferior mesenteric artery route as it ascends from the pelvis to the abdomen. That might show up in anatomy or to tie in anatomy. So keep in mind that inferior mesenteric artery. And that is what causes the kidney to be improperly placed in the lower abdomen. Horseshoe kidney is classically associated with Turner syndrome, monosomy X. And here we have various renal ultrasounds in patients that demonstrate the spectrum of renal abnormalities. You can pause and read if you like, but for conciseness sakes, I'm going to proceed to renal agenesis. Renal agenesis, yes, the lack of development of a kidney. If you look in A, where's the kidney? Renal agenesis is an absent kidney. And in A, it's notable for right renal agenesis. In renal agenesis, kidney formation is absent. The absence may be unilateral, just one side, or bilateral. They're both gone. The existing kidney, if it's unilateral, the one that is there, becomes hypertrophic as a result of the unilateral agenesis, and this raises the likelihood of renal failure later in life because this one singular kidney is doing all the work. Renal agenesis is associated with Potter's sequence, right? You remember Potter's sequence, oligohydramnios and whatnot. Potter's sequence includes the following: bilateral renal agenesis, oligohydramnios with lung hypoplasia, flat face with low set ears, and developmental abnormalities of the extremities. Potter sequence. Now, what about dysplastic kidneys? Well, a dysplastic kidney is a congenital renal parenchymal abnormality that is not inherited and is characterized by cysts and abnormal tissue. As we can see here in this cartoon to the right, the diagram of a normal kidney, and on the right, a multicystic dysplastic kidney. Dysplastic kidneys are typically unilateral. If bilateral, a dysplastic kidney must be separated from inherited polycystic kidney disease. Here we see the ultrasound scan showcasing vesicoureteral reflux. And here we have imaging from a dysplastic multiplex kidneys, both grossly and at the microscopic level. Now, this is something you must definitely know: polycystic kidney disease. This condition results in enlarged bilateral kidneys caused by an inherited abnormality with cysts in the renal cortex and medulla. If you take a look at this image here, this photograph reveals gross pathologic changes in a case of polycystic kidney disease. Potter sequence may be present in babies with the autosomal recessive variant, which manifests in infants as increasing renal failure and hypertension. Polycystic kidney disease is associated with hepatic cysts, congenital hepatic fibrosis, and portal hypertension. Young people with the autosomal dominant variant typically experience hypertension caused by the rise in renin, as well as hematuria and progressive renal failure. In polycystic kidney disease, the cysts grow throughout time. Polycystic kidney disease results from ARPKD1 or ARPKD2 gene mutations. And here we have various representations, both radiologically and microscopically, of polycystic kidney disease. And here we have various representations from patients with various conditions, in particular, autosomal recessive polycystic kidney disease should be noted. Now let's talk a bit about medullary cystic kidney disease. Medullary cystic kidney disease results in cysts in the medullary collecting ducts of the kidneys. To the right here, we can see the renal biopsy findings in a case of medullary cystic kidney disease. Medullary cystic kidney disease is the result of an inherited abnormality. For your purposes, that is autosomal dominant. Renal failure worsens in patients with medullary cystic kidney disease as the kidneys shrink as a result of the parenchymal fibrosis. And with that, kudos to you. You'll remember all of this. I have faith in you. Keep up the good work. Keep studying. Keep making your friends and family proud. And I'll see you next time. Till then, take care.